levetiracetam or valproate, whatever, like institutional reference. Usually we use fosphenytoin. Some centers use levetiracetam. So if you have given 2 doses of lorazepam, you have also given phenytoin, and the seizures continue. By definition, the time is 60 minutes, but the definition is if seizures have not been controlled after these 2 drugs, then it becomes refractory status epilepticus.
I think there are few more questions are there. The sequence we used previously was midas, phenytoin, valproate, phenobarbital, levetiracetam intubation. Okay, but that was an old thing. I think there is definitely, it has been changed now. Otherwise, since there are no new questions, thank you very much, sir.
Definition of status epilepticus, I think we have already defined status epilepticus as a seizure lasting up to 30 minutes. That was an old definition, or continuing seizure without regaining consciousness for 30 minutes. But nowadays we say that any seizure which continues beyond 5 minutes for an operational point of view is taken as status epilepticus. So there is this operational definition and a definition which is used for epidemiological purpose, research purpose is 30 minutes, but for operational purpose, it's 5 minutes. In fact, as I said, any child who comes to your office convulsing is taken as status epilepticus.
Now, the thing was, now valproate doesn't come earlier. It covers beginners. That's why they were asking, okay, valproate doesn't come earlier.
Pardon, Abhay?
Previously, the sequence was midas, phenytoin, valproate. Okay. Now valproate doesn't come earlier. Yes. That's what they wanted to ask.
Yes. Levetiracetam on phenytoin, then phenobarbital, and then valproate comes later. But there are certain situations where valproate can be used instead of fosphenytoin. We have discussed them. The child who is already on valproate and is not taken and is non-compliant, you can use valproate early in those situations. We have already said that. Or if there is a sensitivity reaction to phenytoin, valproate can be a drug, but of course you will not use if there is a hepatic dysfunction.
There was a question related to the diagram. The schedule is old as given in diagram. Is it followed now?
Pardon?
The diagram which we have shown in the end, the flow chart which we have shown, no sir? So yes. The thing which has been asked is, this is an old schedule as given in the diagram.
Okay.
It is good, but it is followed now is a question mark. Is it followed now?
Yes, 2016 guidelines that we have shown you both the things. One was the traditional diagram, and then there is an accelerated protocol. In a traditional diagram, we use benzodiazepines followed by second line therapy, that is fosphenytoin, then phenobarbital, and then coma induction, intubation and induction coma. In an aggressive protocol, which accelerated protocol, which we are now recommending, was also shown in the same diagram, where after second dose of benzodiazepine is combined with fosphenytoin, and then after the child continues to seizure after phenytoin, you intubate, ventilate, and directly start them on midazolam drip. That is your accelerated protocol. Particularly, already the child is seizuring for 30 or 60 minutes. He's been already treated outside. Those are the children where you know that you would definitely need midazolam. You would go for accelerated protocol.
Especially in those cases where we are expecting the seizures to continue. In those cases, instead of following the routine protocol, we will go ahead with directly going ahead with midazolam and intubation.
Yes, agree.
Definitely. Thank you very much, sir. Thank you. Thanks a lot, sir.
Thank you.
Thank you, sir.
Yeah.
We'll proceed with the next talk by Dr. Rakshesh Shetty on rapid diagnostic tests in acute care. Is there any role? Sir is actually the head and pediatric intensive care services, Rainbow Children's Hospital, Bangalore, and is also a founder of Pediastars India. He's also done a fellowship in point of care ultrasonogram, American Academy, has many publications to his credits. We are very happy to have you, sir, today. Over to you, sir, Dr. Rakshesh Shetty.
Thank you, Dr. Arun Kumaran. I hope you can hear me now.
Yes, sir.
Yes, okay, excellent. So thank you, Dr. Abhay Jain, and thank you for giving me this opportunity to talk. So I'm going to talk today on is there a role for rapid molecular diagnostics in pediatric emergencies and in pediatric intensive care units. So this talk, this is my disclosure for the talk. And why it is important? It's important because we are under tremendous pressure as pediatricians who work in intensive care units or emergency area about how do we use antibiotics. At one end, there is a concern about overuse of antibiotics, and at other end, use of inappropriate antibiotics, and both unfortunately are harmful. And the stakes of correct use of antibiotics is far more higher in acute care areas. So let me go through a few series of cases to see, is there a role for us to identify infections much earlier and in a much better way. Okay, so this is a 1.5-year-old child brought to us with fever of 5 days, irritability for 3 days, and abdominal distension for a day. Now, I think today through this course, you've gone through this PALS algorithm. Now, if you were to look, this child is a sick child. This child is saturating 88% room air, has retractions, has respiratory distress, and has a low blood pressure. So, he's in hypotensive shock. These are the set of investigations when the child came. What is noticeable here is a low platelet count, a higher CRP, and high procalcitonin. This dengue ELISA test, IgM, was positive. So here this child was resuscitated initially as per dengue management protocol. Noradrenaline was started subsequently at 0.2 microgram per kg per minute. Meropenem and amikacin was started in view of high CRP and procalcitonin. 6 hours later, the child was intubated, connected to mechanical ventilator in view of respiratory distress. On second day of admission, the child still continued having high fever spikes. CRP was increasing, and the initial blood culture until then did not grow anything. Now, this is a point, it's a concerning because we are not very sure if we have correctly treated this infection, the secondary bacterial infection with antibiotics. Have we chosen correct antibiotics? Or are we dealing with a non-infectious cause for fever? Because oftentimes, now if you look at sepsis definition, we understand it is no longer just infection, but inflammation plays a huge part. Immune dysregulation plays a huge part in the illness. So are we looking at various different kinds of immune dysregulation syndromes like HLH? Now both are a problem because oftentimes we think of HLH and we keep escalating antibiotics, needlessly exposing patients to too many antibiotics and leading to problems of antibiotic resistance in ICU. On other hand, if you didn't choose a correct antibiotic, we have a problem. Why do we have a problem? We have a problem because a study done a few years ago by Anand and his group from Winnipeg in Canada. What did they show? They showed that in presence of sepsis, if you develop hypertension, and if there's a delay in antibiotic choice. When I say delay in antibiotic choice, now we need to understand that not giving any antibiotic is not correct. Giving a correct antibiotic at a correct dose makes a huge difference. Every hour, if you delay in giving a correct antibiotic in a correct dose, it increases mortality by 10%. And that's the reason if you look at surviving sepsis guidelines, it says give antibiotic as soon as possible, preferably with 1 hour, at least within 3 to 6 hours, at least within 3 hours, the antibiotic needs to be given. Now, there's a difficulty here because we are talking about correct antibiotic at a correct dose, right? So this is not like an outpatient department where you would see a patient with pneumonia or cough cold, you would give an antibiotic, wait for a response for a couple of days, see how the child is doing well. By then you have a reports too, and then based on the culture report, based on the clinical response, you might decide to escalate antibiotics. But that's not possible here. It's not possible here because the child has gone into a crisis situation where if I don't treat the patient properly, child might not see next 48 hours. Okay, so that's the pressure of choosing a right antibiotic. So what do we do in our current practice? So we collect blood culture samples before we give our first dose antibiotics. We give an empirical antibiotic. Now the blood culture which is sent takes minimum 12 hours. Okay, there are occasionally organisms which might grow around 6 to 8 hours, but generally at least 12 hours. Sometimes it can take much longer than that to show initial growth. And then the microbiologist would do a gram stain, would do a subculture, and that takes 24 hours for it to grow. And there are sensitivity testing would happen that would take again 24 more hours. So we are looking at minimum 48 hours to 72 hours before we know the organism with its sensitivity. Now this is a problem, and this is a paradigm we've been following for many, many years. And it's a problem because we just discussed that a patient like this, it's almost 24 hours into the care. The culture has not shown anything as of now. The fever is continuing, the infectious inflammatory markers are rising up, and we have enough evidence in literature to say that if you keep delaying antibiotics, the mortality chances becomes remarkably high. So what do we do? So significant advances have happened over last decade. So we are looking at a holy grail kind of an investigation, which is not expensive, which can give us a report within 3 hours, preferably within 1 hour. You should have an excellent negative predictive value. That means if a test comes negative, you should rule out infection. It should not be labor intensive. You can't have a machine which means you're going to employ too many people in the hospital, or sometimes we do hear from labs, the test takes only half an hour, 1 hour to do, but we need a lot of samples. So we can only do it once in 2 to 3 days. That doesn't work. If it was going to do once in 2 to 3 days, you might as well get a culture report. So it has to happen soon, and it should not consume too much of labor and time. And it should be obviously affordable. If it is expensive, already the concern with the patient care and its expense are so much, adding too much of cost is again a self-defeating purpose. So let's see what do we have currently. So lots of interesting advances have happened over a decade. So right now we have two sets of tests for identifying organisms in the blood. One which is dependent on blood culture. The other one is directly over the blood. So what do you mean by blood culture dependent technique? That means I told you that it takes around 12 hours for us to see a growth. Now that growth is important for this kind of technique. It can't do without that growth. So it needs a blood culture bottle that needs to show a growth. Now what it does is a second step onwards where they subculture and then spend for 24 hours and then spend 24 more hours to sensitivity. That part is cut off. So what happens is once you see a growth, then you can identify organisms using two pathways. One is identifying the nucleic acid by using PCR techniques, or the other one is by looking at the protein patterns. So it is done by mass spectrometry. Okay, so Banditoff is a well recognized, pretty much available in most of good laboratories. There are two ways of identifying the organisms quickly. Now, we just discussed an ideal test would want us to give a report within 3 hours. But this doesn't fit that bill, right? It takes at least 12 hours for the organism to grow. And what happens in those patients where the blood culture does not grow an organism at all, and we know the blood culture, especially difficult in pediatric practice, is that the amount of blood we take in younger patients are so small that the chance of having a positive culture rate is quite less. So what happens in those patients? That's where the interest is in identifying the organism directly from the blood. And again, quite a bit of interesting advances have happened in that front. So these are the FDA approved ones, which utilize blood culture based identification techniques. Now, as of now, the only FDA approved ones are the blood cultured ones. The rest of them still are kind of an investigational stage. However, there are many centers across Europe which have been using direct identification. So in our unit, we use film array. It's a biofire based, and it covers most of the commonly seen gram-positive and gram-negative organisms, including yeast. However, there are a couple of concerns we still have in this panel, which they have currently addressed, is looking into the resistance genes, because once you identify an organism, you need to know the resistance pattern. The initial available ones identified genes for MRSA and KPC producing ones. But unfortunately, these are not the common resistance genes we notice in our country. And NDMs, metalloproteinases, are the most common resistance genes we notice. And the initial panel did not cover those, but they've come up with a new panel which covers that too. And that is of significant importance to our country. So there are studies done on this, the blood culture based ones, the film array from BioFire, and it shows that once a culture comes positive, it can identify the organisms with great sensitivity, more than 96%, the organism. So instead of looking at a regular time frame where we're looking at 48 hours to 76 hours to get the complete antibiotic sensitivity pattern, we can get that within 12 hours. So that's a significant advance. So let's look at the other fascinating advances which is happening, because 12 hours is good, but still not that good enough, because there are a couple of concerns with this too. So there are a lot of new models which are being developed, and this is what I'm showing on the slide. are at least the four common ones which have undergone quite a bit of studies. Now, what is the difficulty in identifying from a whole blood sample? Now, why I'm saying this is we hear a lot of companies coming to hospitals and saying that, you send a blood sample, we'll identify the organism and send. There are many of them which are much popping across the country. But the difficulty is, validating those processes. That is where a lot of these tests, that's the reason they are not still FDA approved. Now, the difficulty is when you take a blood sample, it is extremely important to purify nucleic acid because your human cell DNA can interfere with interpretation. And a lot of these techniques, need a very good mechanism where they do a correct nucleic acid extraction. And then subsequently, almost all of these techniques use PCR. But then what happens after PCR is also important. If they use either mass spectroscopy or high resolution MELT. And in fact, these techniques, have decreased the time frame up to 4 hours. It's a significant advantage. And the last one, the HRM, it's very fascinating. And in fact, it uses a lot of artificial intelligence and can identify more than 1,000 organisms with significant accuracy. And that is something to watch out for in the future. So this is just to summarize what I said. The current status quo is not good enough for a sick patient taking 48 to 72 hours to identifying organism with a sensitivity. That's a big problem. And that's the reason why we're struggling with over antibiotic usage or underutilization of appropriate antibiotics. So the current FDA technique has made significant advances in terms of reducing the duration from nearly 72 hours to 12 to 18 hours. But still, there's a scope to reduce it to 3 to 4 hours, and a lot of fascinating advances are happening in this field. So what happened to our case? So we did do a biofire. So what we did was bone marrow culture as well as blood culture, and we sent a biofire too. Okay, so moment they saw in the blood culture a positive growth around 12 hours later, we did a biofire, and what we identified here was Klebsiella pneumonia. So this child was continuing to high grade fevers, inotrope requirement was increasing. The biofire actually showed Klebsiella pneumonia, and this child was admitted in the outside hospital. So there was a huge suspicion of this being a multi-drug resistant organism. So we changed it to colistin, and we added colistin and phosphomycin. So then gradually over 36 hours, fever spikes got better, inotropes were tapered. 48 hours later, we did get a culture report. This was a culture report, showed Klebsiella pneumonia, and that was sensitive to colistin. So fever spikes improved, inotropes were tapered, child was weaned off from ventilator, extubated after 5 days, and then antibiotics were continued for 14 days. So this is one example about how utilizing these techniques can potentially have a life-saving benefit. Let's go on to the second case. Now this is a 15-year-old boy. He comes with a fever for 3 days, altered sensorium in the form of irritability and irrelevant speech. He has one episode of generalized tonic-clonic seizure with continuous posturing. This child was intubated. A loading dose of Levipil was given, just like what Sanjay Bafna said. They followed the protocol of management of status epilepticus, and the child was referred subsequently to our hospital for management. This is his initial assessment, and what we can see is there's a primary neurological dysfunction. So this child was on ventilator. This child was started on ceftriaxone, acyclovir, and vancomycin in view of suspicion of meningoencephalitis. This child was given injection Levipil. This child was also started on neuroprotective measures. Lumbar puncture was done. It showed 30 cells. All of them were lymphocytes and then proteins of 48. Now a question comes. What do we do? There was mild edema, not much on the CT scan. So now the question is, if you look at the current paradigm, we send a CSF culture and we wait for the CSF culture in 48 hours report to come. It's much better than a blood culture. For a bacteria, around 70 to 80% of the time, it comes positive. But the issue is, in a current era where majority of children are getting vaccinated, we don't see Haemophilus influenza meningitis or a pneumococcal meningitis. Does happen, but not that common. What oftentimes we see are viral meningoencephalitis. And oftentimes what most of us do is send for HSV. If HSV comes negative, we might stop acyclovir. If you cannot send HSV, you would continue acyclovir for 14 days. That's the current paradigm of care. And many times based on the cell count, many would continue antibiotics, thinking that it could be partially treated or a culture negative bacterial meningitis. Unfortunately, many of us don't look for various other viruses. Now, why is it important? It is important for a particular reason. And if you go through this case, you would understand why it is important to identify an organism. Now, this was the biofire test we sent on the CSF sample, which is again a PCR based. And you can see the most common bacteria and the most common viruses have come negative. Now, this is particularly important. A negative report is of incredible importance. In fact, when I was training, majority of the status epilepticus, we would just say some viral meningoencephalitis because we didn't have a test to find out which viral meningoencephalitis. We would label it as viral meningoencephalitis. Now, what we have learned is many of those what we thought as viral meningoencephalitis, many of them have turned out to be autoimmune encephalitis. It has a separate treatment. It has good prognosis. And unfortunately, by labeling everything as viral meningoencephalitis, we have lost many opportunities to treat this autoimmune encephalitis. Now, in this child, based on this report, we stopped acyclovir. What we were seeing interestingly over the last couple of months is quite significant amount of children are presenting with neurological symptoms post-COVID. So the PIMS have been described from the hemodynamic perspective, but we are seeing many children coming in status epilepticus. So we thought, oh, could it be COVID-related, post-COVID related encephalitis? So we sent a COVID serology, it did come positive. And this was possible because we had a CSF report which showed it's negative for various other things. So we started thinking about other possibilities in this particular child. So we did EEG, it came normal, culture reports came negative, MRI done was normal, and then we gave pulse dose steroids, child actually got better, got extubated in 3 days, shifted to ward and discharged home. So this child was a post-COVID encephalitis syndrome. So it actually helped us to think, okay, could this be something else? We were thinking if we might have to evaluate for autoimmune encephalitis, for example. All these things helped because we had a report which said most of the common viruses are ruled out in this particular case. So let's go to the last case. This is a 1-year-old, 10-month child presenting with fever since 2 days, change in voice and hurried breathing for last 2 days. So again, if you were to see, there were crepitations, there were recessions, and hemodynamically, however, stable. So the sick-looking child with respiratory distress. So what we know now is looks like a case with pneumonia, the secondary assessment. So pneumonia is a significant problem because nearly 156 million cases happen every year. 4 million of it die. 90% of it happens in developing countries, of which our country contributes significantly. In fact, it's one of the most important causes for mortality. So why do patients actually die because of pneumonia? I mean, they die primarily because they develop sepsis and septic shock. And once you develop sepsis, like what we just discussed, if you don't choose a correct antibiotic, then we'll end up in trouble. So this patient child was started on HFNC, effort of 40%, and initial blood gas showed was reasonably all right. So I thought this could be an acute viral pneumonia. We see this all the time in the winters. The child was managed symptomatically. Initial blood test was also not very remarkable. Normal platelet counts, normal CRP counts, procal was fine. X-ray did show a patch. So we did send a biofire panel. So there are two types of biofire panel to investigate respiratory problems. The one which looks at upper respiratory tract infection and other one looks at lower respiratory tract infection. So we send the LRTA panel. It covers most of the common organisms. And what we saw here was there was a human rhinovirus, enterovirus. Along with that, there was staph also. Now this was quite important for us because what we have noticed of late is despite through this COVID season, lots and lots of children have been presenting with rhinovirus infection, severe bronchiolitis like illness. And oftentimes with RSV and with rhinovirus, we see co-infection of staph also happening. And without this kind of test, it becomes incredibly hard. We would be unnecessarily exposing children with antibiotics. It helps us to give an appropriate antibiotic and stop antibiotic when it's not required. So quite significant number of copies of staph. So because of this, we started the child on linezolid. The child actually got better and the child was discharged. So this child final diagnosis was rhinoenteroviral pneumonia with staph infection. Now, what we have learned over years with the studies coming out from South Africa and also our own study done at PGI is that in the post-immunization world, with the more and more children getting vaccinated, classical bacterial pneumonias have become uncommon. viral pneumonias are slowly becoming the most common reason for pneumonia in vaccinated children. And what we also noticed earlier, the teaching was one organism, one infection. So now the studies have shown oftentimes it is not one infection. It's oftentimes it happens polymicrobial infections. And this is especially true in the flu season. And what has noticed in the flu infection season is children who become really sick, with flu, who land up in ICU with the pneumothorax, airlick syndromes, they tend to have secondary bacterial infection. The pneumococcal infection, Staph aureus infection, they are the significantly common isolated pathogens and they cause significant morbidity in these children. In fact, interestingly, what was seen is when the vaccination for pneumococcus increased in the community, they started seeing lesser and lesser flu patients getting admitted to the ICUs with ARDS. That goes on to say that flu per se generally does not cause that serious infection. When it is co-infected with a bacteria like pneumococcus or staph, it tends to be far more serious illness. And our own experience over years have shown that RSV co-infection, rhinovirus, metapneumovirus, these are most common infections we see. In fact, the study which I mentioned by Dr. Singhi and also a study which I mentioned from South Africa, these are the most common viruses which are currently being identified. Our own study also reflected very similar pattern. When we analyzed our own experiences over a few years, RSV and RSV plus Buka, these are the common combinations which you would see. So with this, I would conclude my talk. There are also studies which are available which can help us to identify pathogens in the stools too. But in the interest of time, I'm not gone through. But what I would say is when it comes to critical care area, very sick children, it does make a lot of difference if you were to identify a patient early. And I'm of a believer that you identify infection quickly, the treatment happens quicker, you save money because you're able to reach your diagnosis much more quickly. You're able to send the patients out of ICU much more quickly. So currently the FDA approved ones are blood culture based multiplex PCR. Does not still fulfill the criteria of the gold standard test. However, that's the best available FDA approved test available in the market as of now. There are a lot of innovation happening in terms of direct blood test identification of organism, but it is still, I think, few years away than being a routine practice. We discussed about how identifying organism in CSF helps in better evaluation of patients who present with status epilepticus. And we also discussed that with viral infections, oftentimes it can be polymicrobial. Secondary bacterial infections are common, and targeted antibiotic therapy is certainly possible with available PCR techniques. So thank you so much for a patient hearing.